Coming up, healthcare in times of crisis.
We are a humanitarian organization. We are in most places, we are there because everything else has failed.
Former Doctors Without Borders executive Uni Karunakara discusses Ebola and the ethics of global health. It's just ahead on Global Ethics Forum.
Our guests today are Dr. Robert Klitzman and Dr. Uni Karunakara. I will just take a brief moment to introduce you to Robert, who is on my far right, and he is professor of psychiatry in the College of Physicians and Surgeons and director of the Masters of the Bioethics program at Columbia University. And on my near right is Uni, who is a former international president of Médecins Sans Frontières and is now senior fellow at the Jackson Institute of Public Affairs at Yale.
Just to start off, why don't you tell us a little bit about how you look at the current situation with Ebola? Tell us a little bit about what do you think made MSF so able to get in there with Ebola and help in ways that other organizations weren't?
Let me go back to my personal experience, and I think that will inform. The last time I was directly on the ground, face-to-face, with an Ebola response was in 2002 and 2003 in Congo, Brazzaville. On the border with Gabon, there's a big forest reserve, and there was an outbreak there. And even in that outbreak, our teams reached the small village where Ebola was raging towards the end of February. Later, we determined that the first transmission actually occurred in October. So even there, you see a delay of certain months. And that also highlights, in some ways, the dysfunctions of health systems. So first of all, it happens in remote places. And then it takes a while for the news to reach because one person dies, no one thinks that this could be Ebola, and then another person dies. But then when teams start or health systems start putting two and two together, then the capacities don't exist in the capital to know what's going on. By the time it works up the chain, it takes some time, and a lot of people are killed. In the past, in most of the outbreaks, they happened in very remote places, and the numbers were actually small compared to what we are facing in West Africa today. The numbers were very small. And there was a sort of a division of labor. So the Ministry of Health normally was responsible for working with the community, passing on messages, enforcing small sort of movement restriction policies. You need to restrict people from moving from one village to another to prevent transmission, spread of infection, etc. So the government did that. CDC would come in, they would have a lab in a box, and they would sort of confirm cases. WHO would do the epidemiology, they will do the contact tracing, they will identify, because contacts, it's important to trace contacts because that's how you follow and make sure that the further spread doesn't happen. And then an organization like Doctors Without Borders, MSF, we would do the case management. Now, this worked reasonably well when the outbreaks were small. But what we saw in West Africa was almost like a perfect storm. First of all, it hit the first transmission, known transmission, was in Dwekedu, which is a town in Guinea and the border with Liberia and Sierra Leone. Right? Now, unlike in the previous outbreaks, this happened in a peri-urban area, so a densely populated part of the world, and very mobile people. A friend was telling me that even the dead travel because they carry dead bodies to other villages, etc., for burials, so that the disease spreads. So peri-urban, very mobile population, and none of these three countries had prior experience of Ebola. And that's, first they thought it was Lassa fever, which is another hemorrhagic fever. And so a lot of the measures that initially they put in place either didn't work or were not appropriate for this disease. And then by the time the international response kicked in, because of the mobility and because of the density of population, etc., it was out of control.
Maybe just as a little background, do you want to say something about Ebola as a virus? I mean, why it keeps popping up in areas and how it's spread, or I mean, how does it come to this village at the border of these three countries? Or
So no one quite knows where the natural reservoir of Ebola is. It's now thought to be bats, and then from bats. So for example, in 2002, 2003, we had also got reports from forest rangers who were working in that forest that there were large ape die-offs. So apes were dying in very large numbers, monkeys, apes, but also porcupines, deers, etc. So then humans started dying. So they were worried that somehow this was perhaps connected, and they had called. And I think in many of these, this part of the world, people do rely on forests for their sustenance, whether it is for fruits or for meat. So it is completely conceivable that the transmission occurred in one such encounter or one such contact, and then of course it sort of spread. Now satellite infections happen because people move from one place to another. Now there is incubation period of 7 to 21 days. Now these are days when people move around, they're completely asymptomatic. You don't transmit the disease till you start showing symptoms. But then by then they would have moved to another area, right? So that's, and then another satellite a cluster of infections can happen. But the other thing is also there's a lot of fear and misinformation that is spread. There are conspiracy theories that this is plot to by the West to somehow depopulate West Africans. In Liberia, there was a whole strike that was going on just before the outbreak. The health workers had gone on strike for better pay, and there was another rumor that this virus was deliberately released so that this would force the hand of the government in the pay discussion. I mean, this is the nature of discussion. So there's a lot of rumors that, and you can imagine when people are dying, it happens. There are also cultural beliefs that play a big role. In most of these places, the communities believe that illness and health is mediated by spirits, right? And one way of addressing that problem is by, when elders die, there are certain rituals that need to be done. One of it involves the washing of the body. And this again is an important form of spread because the body is highly infective when they've just died. So there are so many different elements and factors, and we are not just telling them, okay, this is a virus. You also have to negotiate and sort of engage with communities to understand why they need to change some of their practices in order to stop the spread of Ebola. And we're not very good at communicating, and that we find again and again and again. So measures like quarantine, isolation, etc., without really engaging with the community and letting them know why these measures are necessary, don't really work. In fact, quarantine measures were, in Sierra Leone, for example, this was a disincentive for people to actually seek healthcare, because they didn't quite know what that was. And for an ordinary person, what they see is a family member is taken away to an isolation ward, and next thing they know is they get a dead body back, right? So I think there has been a big failure of communication and really getting the communities along in the fight against Ebola. But even in this country, in the US, there's a lot of fear. The way CDC guidelines have been employed by, let's say, Governor Christie and others, it's been not science-based. It's based on fear and politics, right? They want to show that they're in charge of the situation, so the policies have been implemented. CDC has very good guidelines on how Ebola, people who've come in contact with Ebola should be dealt with, but they haven't necessarily been followed in the way they should have been.
So let me switch topics a little bit to issues of global health ethics more broadly. So MSF has done, as I said, amazing work, but there are also various moral strains and dilemmas that MSF faces or has faced. I'm wondering if you can tell us a little bit about what some of those are or how the organization faces tensions that come up.
Today, from an organizational perspective, there are perhaps two broad set of challenges. One is to reach the people who need assistance. So these are people affected by conflict, disasters, epidemics such as Ebola, and in many cases, people who are neglected by their health system or by their government for their politics, for their religion, etc. So conflict, disasters, epidemics, and neglect. The other broad set of challenges is ensuring that once you reach these people, that we are able to provide them with good quality care. There are increasingly many places in the world that we are not able to reach populations in distress because of conflict. So today, Somalia is one such place. Syria definitely is in one such place. And there are parts of Afghanistan, Pakistan, South Sudan, Central African Republic. Here, it is becoming increasingly difficult to reach patients because of the conflict and because of all of the attendant problems. Geography is also sometimes a problem. They're very remote, etc. So that's one set of challenges. And there's also a perception in some quarters, in fact, both ICRC, the International Committee of the Red Cross, and MSF, they both started campaigns sort of highlighting the fact that health workers are increasingly at risk of providing health care. So doctors are being targeted just for being doctors. Nurses are being targeted just because they're nurses. And increasingly, and journalists are also another profession that is also greatly at risk. The other set of challenges today, we have a situation where many life-saving drugs which are available in the West, in countries where we live, are not available to people in poor parts of the world. And this is not because the drugs are in short supply, it's because the way we do business, the patent regime, intellectual property rights, etc., the cost of the drugs are so exorbitant that people in poor countries are not able to afford it anymore. So there is these dual challenges as doctors and humanitarians. We deal with these issues almost every day in the field. So once we get there, what kind of care can we provide them?
So many people here and others who may be listening or watching are involved in government agencies, international agencies. Obviously, more funding is important for WHO, but beyond that, are there kinds of policies beyond just giving money that can help, either around patent protections that lead to high prices of drugs, or other things that governments could do or government agencies could do or should consider doing?
I think as citizens, we have a responsibility to keep our government honest and to kind of put pressure when needed for appropriate policies to be put in place. Right now, trade negotiations, TPP, for example, the Trans-Pacific Partnership, talks are being held completely in secret. We don't know what is being negotiated. The people of this country doesn't know you don't know what the government is negotiating in these treaties. So these are things I think we should hold the government for more transparency. We want to know what is being negotiated. We want to know what trade talks involve and what is being signed away, or what kind of pressure are we putting on other countries. We are worried as an organization that if some of these, if the treaty is signed, that it could actually be more difficult for us to provide effective care in the field, because the price of drugs are going to go up and some other problems associated with it. So this is just one example where as citizens and as individuals, we can put pressure on the government and also be more aware of what the issues are. Ebola, we could have pushed the government to act perhaps earlier and more forcefully. In fact, we send soldiers in before we send doctors. We need to worry about this.
I think something is terribly wrong, structurally wrong. And you mentioned the mistrust, which is so important. Question to both of you, is the problem not the psychology of aid? These aid flows that are going either through multilateral or bilateral channels to Africa are not being regarded as aid. You don't like to get every time a present. You also want to give something back. And I'm amazed, and now I stop, that in the whole development cooperation business, the issue of the psychology of aid is not being treated.
Easy question. So, speaking from my past role with Doctors Without Borders, MSF, see, we are a humanitarian organization. We are not a development agency. We are, in most places, we are there because everything else has failed. We are there because politicians haven't been able to make true on their commitments. The international community has not been able to build peace or build the appropriate response. We are there. In fact, our presence is emblematic of a huge failure in everything. So we are there because everything else is broken. So you have to, and of course, yes, development assistance is meant to build systems, but we also need to have the staying power. If you give them funding for a country for 3 or 4 years and then you change your priorities, international community and the bilateral funding, very often we have attention deficit disorders where we don't stay with certain commitments, we change our priorities every too often, and these governments also respond to that. They're willing to put in effort and money when they're not sure of the commitment of donors. One good example is the Global Fund, I would say, in spite of all the criticisms that you can level against the Global Fund for, to fight HIV, AIDS, malaria, what they've done is they have brought some predictability to funding flows. As a result, in the last decade, we've been able to put 12 million patients on HIV treatment, right? So this is a good example where ministries of health, initially there was a lot of resistance to sort of get anything, to change anything in countries, but the moment they realized that the funding flows are going to be steady and they can plan on the basis of that, then you started seeing change. Ministries of health changed their structure a little bit. They were able to put more and more patients on treatment. In the year 2000, there was not a single patient on publicly funded HIV care. And today you have South Africa guaranteeing free treatment for every single HIV patient. So changes happen. So in fact, in the last decade, you can call it the golden decade for global health. And that came across because of several reasons. One, there was a global commitment, money was put in. Second, generic companies came together and bought the price of ARV treatment from $10,500 per person per year to less than $100 per person per year. Now it was possible for ministries of health to buy medicines and to provide it for patients. There are many different elements came together to make these changes possible. But now it's all under threat. There is a real risk that these trade policies that are being negotiated are going to go back on and make, they put a lot of pressure on companies so that the prices of drugs will go up. The financial crisis that we had a few years ago has led countries to decrease their commitments, and many of the patients who were on treatment now have to transition to second-line, third-line treatment, which are far more expensive than what it was in the past, right? So many reasons that we should be worried about the gains that we achieved in the last decade or so are at risk of being, we are going to lose the momentum if we don't stick with it. So that's why, when I talk about staying power and stamina, we have to have the will to see certain things through. And very often that's not the case when it comes to development issues.
It's important to also take a historical perspective. So the countries in Africa where we're seeing Ebola for hundreds of years were colonies of Western countries. So for instance, the Congo was a colony of Belgium, et cetera. The major European powers, Portugal, Great Britain, all had colonies. And often those were not good experiences for these countries, shall we say, where the model was that the Western European country, and of course the United States essentially had colonies elsewhere as well, would sort of take from the colony, and there was really very little sense of giving back. So I think that's partly what's created a sense of, at times, resentment, mistrust, et cetera. I think that aid now, in the past few decades, is reversing some of that trend, but it does take time. So I think there have been improvements, and those are important to realize. We can't wave a magic wand and cure everything all at once, but I think there has been progress.
My underlying question has to do with your remark about dysfunctional health systems. So what can be done to have functional health systems? In other words, starting with, how do you have doctors and nurses who will stay in their countries and not come and work at Yale or Columbia or somewhere here and make a lot more money? I mean, this is what happens, the so-called brain drain. How do you do that?
The solution is completely outside the area of health. It's good governance. We're talking about other conditions that need to exist for a health system to flourish. It's not going to kind of develop and exist in a vacuum, right? So the reasons educated people leave, and it's not just doctors and nurses, because they want everything that we want. They want to live in a place where there is hope of some security. They want better future for their kids, and they have the skill set to get jobs outside, in another country. So I wouldn't fault them for seeking a better life elsewhere, but how can we then create the conditions in which they can feel safe and their kids can feel safe? And that is a much larger question. Doctors Without Borders is just a small attempt to plug a hole or fix a leak. It's not going to solve any of the problems. We are there, like I said, because the systems are broken down. But development, I think, is a contract between the citizens and the people they elect to power. They have to fight it out, figure it out, what kind of systems that they need, whether it's health, whether it's education, etc. We can provide some help, and we can, as international community, we can assist. But in the end, the people and their governments have to figure out the kind of government they want. It cannot be imposed from outside, but we can somehow nudge them along or support, but they have to make the decisions on how best to develop their systems. And I have ideas, but I certainly don't have the solutions for any of these countries.
I think there are potential levers in various ways. These are big problems that are multifactorial. But for instance, I'm no expert on the IMF, the International Monetary Fund, and the World Bank, but if there are outside funders or countries giving aid to these countries, we know that one problem is corruption in various countries. So you have ministers of health that unfortunately siphon off a lot of the money. So even if we give aid for health to country X, the percent that actually reaches the citizens of those countries who need it is not as much as we'd like. And I don't know how much the IMF or the World Bank or the US government or others who provide funds under whatever terms of those countries could make it a factor that there be more transparency, that there be efforts to fight corruption that extend to the healthcare system. So I think there are areas that we can improve on.
Again, a note about corruption, if you allow me, is I have interacted with many ministers of health. Of course, there are some exceptions, but by and large, they're also trying, right? In ministries of health, if you want to make big changes in the country and if you want to get big investments in health, you should actually be talking to ministries of finance, not ministries of health. Very often they're also fighting for budgets with ministries of finance in their own country. But even if you take corruption out of the mix, the budgets are so small. In Central African Republic, for example, Doctors Without Borders run 4 hospitals, 4 small district hospitals, and we are outspending the country's health budget. Just 4 health. So this is, and someone else remarked, every time a doctor, an MSF doctor in Liberia, puts on the protective gear, that 1 hour, they're already outspending the per capita investment in health for Liberia. This is the gap that we are talking about. Corruption is one thing, but there's just not enough money in the system to have that big an effect, corruption to have that big an effect. So there needs to be an injection of cash. Now, how we achieve that, I can't say, but there are serious issues that we need to address. And a lot of the solutions lie outside of the health system and not within the health system.
Uni and Robert, thank you so much. It was really a perfect moment. Thank you. Really, thank you. Really. Thank you.
For more on this program and other Carnegie Ethics Studio productions, visit carnegiecouncil.org. There you can find video highlights, transcripts, audio recordings, and other multimedia resources on global ethics. This program is made possible by the Carnegie Ethics Studio and viewers like you.